Monica, we are live now.
Good afternoon, everyone. I'm Dr. Maunika, medical advisor from Shield Healthcare. I welcome you all for today's session, DSOG Aesthetic and Sexual Medicine Committee. Webinar is on sexual health in association with Rajasthan. I hand over the session to Dr. Apurupa. Dr. Apurupa Datta. He's an MS gold medalist, FIAGO, FMAG,
Monica ji.
and RCOG Associate London. Yes,
Monica
sir.
ji, thank you so much. Thank you so much.
Yes. Yes.
Absolutely. Thank you so much.
And I welcome Dr. Monica Gupta. She's MBBS, MS, Gynae and OBG. And I hand over the session to you both, sir.
Okay. Thank you so much. Can you just stop sharing? Yeah. So I welcome you all the societies of Rajasthan. So, my dear friend, today we are here to discuss a very important but very unspoken topic about the sexual health. So, I thanks to all the president and societies of Rajasthan who agreed to be part of this webinar and spread the knowledge of sexual health. My dear friends and colleagues, as we know, in our culture, we always start something new, something good from the blessings of our seniors. Today, we are really blessed to have our chief guest, a very special person for us, a teacher par excellence, teacher of teacher, a person, I can say, the past Foxy president who is accessible to each and every Foxian. Each and every Foxian, whether he is practicing and want to connect with ma'am is so easy to approachable. So thank you so much, ma'am. Ma'am, you are an icon for all of us. You are an ideal and inspiration for all of us. And we, especially those who are dealing with the high risk pregnancy, those who are in the laparoscopy and whatnot. Thank you so much, ma'am, for giving us your time, valuable time, and for in your busy schedule. And we all know ma'am doesn't need any introduction. Ma'am has received the 4th highest civilian award of India, that is Padma Shri by President Pranab Mukherjee. And what not, ma'am is awarded with the BC Roy Awards, and ma'am is the past HOD of the AIMS. He started the laparoscopy unit at AIMS. Ma'am is the past president of the Foxy, past president of the AOGD and whatnot. Thank you so much, ma'am, for coming us and for giving us the time and giving us your blessings. Over to you, ma'am, for your kind words.
Thank you so much for your kind words, Apurva. आप इतना मीठा बोलते हो. You are a most appropriate person for sexual medicine committee.
Thank you so much.
Actually, I have been working with Neeraj Jadhav. I have been to Rajkot on his invitation. He is such a dedicated, hardworking boy. And he took over from that team of Aurangabad, Ajay Mane and all. So these boys for decades have been doing such good work. And now I'm very happy to see this young, charming, and I just asked Leela which place he belongs to, from Ranchi. So there are such good talents like you, Apurva. And please continue. This is an area which is a taboo. Nobody wants to talk about it. It requires a lot of courage for youngsters like you to take these topics and along with females work on that issue and disseminate information and knowledge, which even we gynecologists are ignorant about. There were times, if they say sexual dysfunction and all, we quietly used to send to andrologists, urologists. But time has come, we gynecologists take these issues seriously. Now it is the quality of life is also very important. And you know, from sexual disorders, so many women and couples suffer. So Apurva, I congratulate you and I really respect your zeal to work in this area. And I wish you all the best. And I saw a topic, vaginismus, and today only I have seen 2 patients of vaginismus. It's getting common. So, and treatment is very simple, but you have to spend a lot of time in counseling. which we gynecs are not having. So we have to change our attitude. We have to keep counselors. We have to, alleviate the sexual. And now patients are opening up. Good olden days, they were never saying us. Now so many come, I'm not able to have good orgasm. And we should not laugh at them. We should be very sympathetic. We should try to improve their sex life. And with these words, I don't want to say much, but I'm really impressed with Apurva today. Very sweet young boy with all the charm. So I wish you all the best in future also, Apurva.
Thank you. Thank you so much, ma'am. Thank you. Your words actually made my day, ma'am. Thank you so much for your time and valuable. Thank you,
So
ma'am.
I wish lot of success for this program.
Thank you. Thank you so much, ma'am. Thank you, ma'am. Thank you. So after our chief guest now, I would like to introduce our first guest of honor. Again, very, very dear senior of my, the fitness is, again, she is an inspiration for all of us. Ma'am, your Anthu, your energy level, VGL, हम लोग बोलते हैं अगर मैम का 10% भी हमें मिल जाए तो भाई हम लोग का किस्मत बन जाए. So thank you so much, Leela ma'am, for coming and agree to be part of this webinar and for your blessings. Ma'am, we all know is the past vice president of Foxy 2018, is the chairperson of the ISAR Rajasthan chapter.
Just we can start.
Thank you.
We should. Everyone is means eagerly waiting for these topics, huh?
Yes, ma'am.
Yes.
Yes, ma'am.
And
Thank you, ma'am. Over to you,
today
ma'am.
you can
Yes,
see
ma'am.
that me and Madam Kriplani, we are sitting all together.
We are very old friends. So common for sexuality.
Thank you. I'm honored to share this stage with Dr. Kriplani ma'am. And we are all old friends and we work together. And I used to go in Madam's every OT. I think I've entered in your all OTs and all. So, and we were discussing about this sexual medicine. And that is a very important thing which we should take forward. And Madam rightly said that these are the topics when they are coming, हम कहते अरे भाई ठीक है ना, चलो थोड़े दिन में हो जाएगा, थोड़ा ऐसा हो जाएगा. But no, it is again a part of there, and definitely the quality of life, even this is functional as well as this, the quality of life is one part, but some problems are there. Like the infertility. I was sitting in Madam's chamber and the patient came for that infertility and they rightly said that business is there. Madam took her and then counseled for, I think 15 minutes you have counseled. And then they realized that she was saying कि मेरा एक IUI है, that was done under GA. But Madam counseled and Madam said, no, I'll do without GA. So the counseling and to spend time in all these topics and this, and Neeraj, really congratulations. You have just means awareness you have created in means next level. So this, and I think this light will be taken by Apurva. My wishes are with you and you'll do.
Thank you
And
so
all
much,
my
ma'am.
Rajasthan societies, those who have taken interest in doing this, and both the speakers are from my dears all, Taruchaya and Monica, and all society president, secretary, Savita was there, I saw her, and all other must have joined. So it's this topic should be carried forward, and then you all take interest and then help our patients while giving them time regarding these topics. Thank you. Thank you very much.
Thank you. Thank you so much, ma'am, for your kind words and for your blessings. Thank you, ma'am. So again, I would like to invite our second guest of honor, Dr. Anju ma'am. Anju ma'am is like a brain with beauty with brain. So ma'am, I always admire and I am a great, admirer of your dressing sense. Really, I always used to show your photograph to my wife and say, "Bhai, Anju ma'am se aapko seekhna chahiye." So thank you so much, ma'am. You are always being there, always blessed us. You are always guide to me. So thank you so much, ma'am, for your always being there, always your blessings. Ma'am doesn't need any introduction. Ma'am is the Secretary General of Indian Menopause Society. Congratulations, ma'am. Ma'am, party abhi due hai uska. And ma'am is at present the chairperson of the AIDS and STD committee, Foxy. And thank you so much, ma'am. And whatnot, over to you, ma'am, for your kind words.
Thank you, Apurva, for your kind words. Of course, my first pranam goes to Dr. Alka Kriplani. Alka ma'am, pranam. आप राजस्थान के ही हैं और आपके साथ मिलने में बहुत मजा आता है. And dear friend Leela, she is also another star of Rajasthan. And congratulations, Neeraj, you are really, your committee is doing immense work, the work which is really required, for any committee. And you have brought in lots of awareness, and you are regularly conducting this program all over the country. Congratulations to you, dear friend. And of course, you've got a beautiful star with you, Apurva, who is, a star found by you, who has been there with you like a, Hanuman, I must say. कि हनुमान ने जैसे राम जी की का ध्यान सेवा करी, वैसे Apurva has been there like Hanuman, loyal to you always and looking after every small and big thing. So my best wishes to you. And of course, when we talk of sexual medicine, it is a branch which even we gynecologists are shy from. And in our day-to-day practice, patients do come to us with lots and lots of problems. First of all, I practice high risk and infertility, but another branch which I practice is, menopause, where a lot of women come to us who have problem with, painful intercourse, who do not have sex for fear of pain, and then they have this problem of libido also. So these are the females who don't come out, and all these problems can lead to their poor quality of life, poor for husband also, they are not being supportive. So these are few factors which are very important as doctor for us to understand that how we can solve their problem. We have to come forward without removing the taboo or removing the fear from our patient's mind, and give them way forward that how we can help them. It is very, very important. And of course, we have to be very empathetic to these women, that, these are the problems which are day-to-day problem, and they can be solved easily. And we have to tell them the solution. Main thing is we have to come forward, dig out the problem, because they will be shy to talk about their problems. So we have to be at forefront, and in some way we have to take out our problem. As Dr. Alka Kriplani just said, I also had one of the patients, very recently, last week only, she came for IVF and she did not even want to have a vaginal ultrasound, and she'd been married for 5 years. Husband semen normal, her ultrasound normal. But when I went into the depth, they did not have vaginal sex for last 5 years. They've been married. So I had to, take their sessions and, regularly tell them that you have to do this, you have to do this, give them very empathetic corner of our doctor's medicine side. And then now she yesterday only came to me that she is pregnant without IVF, of course. So that is what I want to say, that in day-to-day practice, we come across this problem, and we have to be empathetic to the patient. We have to listen to her and then give our soft corner to them so that we can solve their problem. And my best wishes to you. And again, congratulations to Neeraj for the good work he is doing in Foxy. Of course, both of us will retire soon, and next year our committees will merge. So I think we must do a ceremony also together.
Yeah, I'm coming on Sunday, na? So we will do ceremony on Sunday. Definitely in Jaipur.
So welcome, and we are waiting for you to be in Jaipur also. So welcome to Jaipur.
Yeah.
Thank you, Anju ma'am. And you have correctly said, many times an unconsumable marriage, it's looking so, it sounds so okay, unconsumed. When they are married, they must be consumed. But there is a number of patients, a lot of patients, the infertility only due to the sexual problem. So very correctly point out, ma'am. Thank you so much for bringing out this. And thank you so much for always your blessings and kind words. Thank you, sir. So the next is Neeraj Jadhav, sir. Sir को मैं क्या बोलूं? Sir ने मुझे बनाया, sir ने मुझे उठाया, and whatever I know, हम लोग कहते हैं हिंदी में हाथे, बंगाली में हाथे खोड़ी. means you have to बच्चे को ABCD लिखाते हैं, क ख ग सिखाते हैं. He like he's like वो हाथे खोड़ी जो मेरा है वो नीरज सर ने किया है ना. Then everything whatever I am today or whatever I am doing today is due to Neeraj sir. And sir doesn't need any introduction. We always
it's okay, Apurva. No more introduction.
So,
It's enough.
thank you so much, sir, for always being with us.
Yeah.
Thank you, sir.
So thank you, Apurva and Monica, for making me part of this webinar on sexual health. Apurva and Monica both were very active member of my committee. Unfortunately, Monica has shifted to some other committee, but Apurva has continued to work with me in this year. It gives me immense pleasure whenever I see any webinar or any program related to sexual health. So I must congratulate all the societies of Rajasthan who have joined today for this webinar. Why? Because we as a gynecologist have a very important role about the SHRH. What is SHRH? That is sexual health and reproductive health. But somehow we have forgotten sexual health and we are only concentrating on the reproductive health. Why we are so much neglected about the sexual health? First thing is, this subject is not taught in our medical college. Still, there is a taboo associated when word comes sex in any problem. So we are so much hesitant to discuss the issue openly. We have a so much busy OPD and sexual medicine takes lots of time. So naturally, we are not that much keen about making more interest in this subject. But as a OBGYN practitioner, sexual medicine patient is very much familiar with us. They have very much rapport with us. They can share their intimate problem with us freely if we encourage them. But problem is that we are not that much comfortable with because of so many issues. So we have done so many programs in last 3.5 years, and I'm so much happy that now many people are talking about the sexual health and many webinars are happening. So I hope that you will enjoy today's webinar. And what I say about Apurva. Apurva is my right hand since last 3.5 years. Without Apurva, I would have not done so much activity if he was not with me, because it takes a lot of efforts behind the scene to take the chairperson, to take their CVs, to collect their CV, to make the flow of the event, and to make everyone is there during the program, punctuality, all thing was done by Apurva in our program. So I wish Apurva all the best, because he is the right choice maybe. So I request all the president and secretary who are joined for today's webinar, please support Apurva in the election of our next chairperson election, which will be in August. So on that note, I end up my speech, and best of luck, Apurva, and over to you. Apurva, you are muted.
Thank you. Thank you so much, sir. What to say about you, sir? बस और कुछ नहीं बोल सकता हूँ, sir. Thank you so much, sir. Thank you so much. Thank you so much. So, Monica ma'am, should we start with our scientific program?
Sure.
Yeah. So, can I request you, Monica ma'am, to introduce the chairpersons? Actually, Pushpa Nagar ma'am is an emergency, and Pradeep sir is actually joining. Nikita ma'am is here. So please introduce the chairperson, and then, yeah. Monica ma'am. You have to unmute yourself, ma'am. Yeah.
Mani, I'm unmuted now. She's from Sri Ganganagar. She's the president of Ganganagar OBGYN Society, a leading practitioner from there. Welcome, Dr. Nikita, as a chairperson. Dr. Pradeep Bandwar, he's a secretary, Udaipur Society. a good person, a good laparoscopic surgeon, infertility specialist in the Femicure Hospital. Welcome, sir. Welcome both the chairpersons. And I introduce the speaker of today, the star speaker, Dr. Taru Chhaya. She's very humble, very affectionate, very helpful. If you want any solution, she's having all the solutions in her hand. She's a director of Bansal Hospital, Shamnagar, visiting consultant, Cocoon Hospital, member of Foxy Breast Committee, past secretary of Jaipur OBGY Society. Her
Monica, it's all okay.
Didi, to your talk, please.
I share my
Yes, ma'am.
screen.
Yes, ma'am. Nikita ma'am is there. Yeah. Nikita ma'am, we start the first topic. Okay, with the permission. Yeah. Okay, ma'am. Thank you so much, ma'am. Yeah, Taru ma'am, it's visible.
It's visible now?
Yes, ma'am. You can make it full screen, ma'am. Yeah, absolutely.
So today we are speaking on teenage pregnancy and POXO Act. Should I have to increase the volume? It's okay.
Ma'am, it's absolutely okay.
It's
Yeah,
okay,
ma'am.
ma'am.
You're audible. Yes, ma'am.
So what is teenage pregnancy? We all know teenage age up to 19. So technically the pregnancy that occurs in girls up to 19 years of age is teenage pregnancy. But the girls aged 12 to 14 years are more likely to be victim of unplanned and unprotected sex because they are unaware of all these things. And about 2/3 of teenage pregnancies occur in the girls aged 18 to 19 years of age. So what is the prevalence in India? According to UNFPA, their report released in 2013, there were 7.3 million girls who got pregnant or they gave birth at the age of 18. And our India was one of the top 10 countries. It was amazing and very bad to understand also. Here India is in bad top 10 countries. So what is the reason why this all happens? So because there is a lack of proper sex education. In our country, we are all having taboos about this. We should not talk about this. All children, all girls, especially in our household, they are always educated like this by their parents and dadis and nannies. Don't talk about this. So there is lack of proper sex education. There is party and child marriages. हालांकि child marriages के ऊपर much action is going on these days also. So child marriages have reduced, but still there are. There is a peer pressure by friends. They get carried away with the pressure of their friends. Exposure to media, because media and films these days, there is no filtration of obscene scenes. So they're attracted because that is hormonal age. Drinking and smoking also, abuse of drugs make them lose consciousness and what is wrong and what is right, they don't know that time. Lack of supportive parents and families, a child deprived of love. These days, earlier it was not there, but now these days there are broken families. So and the mother is working, they are going on their work and they don't know what the child is doing. They're dependent on nannies and they depend on dais. So another is the exposure to sexual violence, unhealthy environment at home, stressful lifestyle, and lack of awareness because they don't know about contraception. So what are the effects of teen pregnancy? Most of the teen mothers are either pursuing college, they drop out, or she becomes a mother, so they don't know what to do, and there are financial pressures as well. So the couple who get married because of children, at times, either they leave their work or they end up in divorcing each other also. So teenage pregnancy limits the bearer's social interactions. At the time when she should be enjoying the lifestyle, friends, movies, outgoing parties. At that time, she is becoming a mother. And they themselves are financially unstable. So they pressurize their parents to raise the child also. And they themselves don't have any parenting skills. So there are risk factors. What is the complications of teen pregnancy? Because that risking mother as well as risking the coming baby also. So there is more chances of death rate of the baby mother because their body is not still stable for childbearing. The chances of premature labor, they're anemic because they're nutritionally deficit. Placental problems are also there. Depression can be there because they don't know what to do about this and because of social taboos as well. Baby occasionally or mostly born underweight because mother is also nutritionally not good. Premature babies because of prematurity. Neonatal mortality because the babies are underweight and premature, the neonatal mortality is more. And their developmental issues are also there because of delayed milestones, mental retardation, and other disabilities. So this is the same thing in a picture values. How to prevent it? Over past decades, India was successfully doing many programs to prevent this. Mass awareness and legislation. Many acts have done, and mass awareness day-to-day basis ke upar. They're trying to make our whole population aware. Basic knowledge of menstrual health. Recently, there was a competition also from Foxy on menstrual health. The basic knowledge of menstrual health is being given by health workers in public. And there are many educators who are trying to bridge the gap between social and medical issues. They provide general health education about risk of teenage pregnancy. They strictly enforce the minimum age of marriage law by law, so that at least they'll follow that there should be no sex before 18. Even if at the age of 18 and there is marriage and suppose some patient comes to you around 18 and a half years of age and she's full-term pregnant, that is also unlawful. It provides at-risk mothers with education because they won't be able to complete their education in case of their pregnancy. So government has come out with a POXO Act. Then I'm here to just explain what is POXO Act. Protection of children from sexual offenses. This is POXO, POCSO. It came in force with the effect of 14th of November, Children's Day, 2012. It's applicable to whole of the India except J&K. POXO Act 2012 defines a child of any person below the age of 18 and provides protection to all children under the age of 18 years from sexual abuse. We are coming to that also. What is that? It also intends to protect child through all stages of judicial process and gives paramount importance to the principle of best interest of child. So what are the offenses covered under the Act? Penetrative sexual assault, aggravated penetrative sexual assault, aggravated sexual assault, they're different. Sexual harassment, using child for pornographic purpose, and trafficking of child for sexual purpose. What is penetrating sexual assault? What's the difference between them? When someone penetrates penis to any extent to vagina, mouth, urethra, or anus, the male or female, and makes the child to do so with him or any other person, it is penetrative sexual assault. But what is aggravated penetrative is whoever commits penetrative sexual assault on the child and makes the child to strip or parade naked in the public. That is aggravated, means some aggravation is there beyond penetration. Another is sexual assault and aggravated sexual assault. Sexual assault when somebody touches some other person in sexual manner without consent. It includes unwanted kissing, sexual touching, but there should be no consent. And what is aggravated? A sexual assault that involves serious violence, of threat of serious violence. See, I will injure you if you don't do this. So this is aggravated. What is sexual harassment? They're different words, but meanings are also different. Means behavioral characterized by making of unwelcome and inappropriate sexual remarks or physical advances in a workplace. अपन काम कर रहे हैं, ऑफिस में है, बाहर बस स्टैंड पे वेट कर रहे हैं, and वहां पर somebody remarks on you. This is sexual harassment. And there were 2 more that were very clear by their own words: using child for pornographic purpose and trafficking of child and sexual purposes. So these are the offenses, they are covered under this act. So it is mandatory to inform police. So what is there by these problems? Act prescribes stringent punishment graded as per the gravity of offense. Whatever offense is being taken, under which aspect the offense is being done, with maximum term of rigorous imprisonment for life and fine, along with fine and imprisonment. So it is mandatory to inform police. Yes. Section 19 POSCO Act, Section 357C CRPC, both instruct the doctor, hospital, mandatorily inform police. Even if she is married, if she has sex before the age of 18, you have to inform. Section 21 POXO Act and Section 166 BIPC prescribe punishment for not following the direction of Section 19 POXO Act, 6 months imprisonment and fine. So everybody in their own force, they should know in your area ka whatever jo thana hai uska number and what is email ID of that thana. That is very important. One should know, so that you have to inform police if such patient is coming. Suppose a patient comes to you and you, out of your some sympathy to the patient on something, you say, okay, I'm not going to inform, just relax. And that patient goes to somebody else and वो वहां पर पुलिस को inform करते हैं, and police inquire करते हैं, she say, I went to that doctor also, she did not say anything, then you are also liable. So भी अपने को बचाना भी उतना ही important है जितना हम patient को बचा रहे हैं. So whom to report? Special Juvenile Police Unit and local police and Child Welfare Committee. So this is our new parliament. Thank you so much.
Thank you so much. It's so crisp, to the point, and really an eye-opener to all of us. I would like to invite our chairperson, Dr. Nikita ma'am, to please your inputs and your comments. Nikita ma'am.
Thank you. A very to the point talk by Dr. Taru Chhaya, and it's really good that we are taking up this topic, because this topic has been neglected till now, and it's still neglected, as others have said, that we still hesitate talking about the sexual health. You have really put up the points very well, and thank you, Dr. Taru Chhaya, for that nice talk.
Thank you, Nikita ma'am, for being there and for chairing the session. Pradeep sir.
Share screen. इसमें click करेंगे ना?
अभी तो रुक जाए.
Pradeep sir. No, I think actually sir is driving though, so he will be he will join after some time. So we will come to our next lecture. And for chairing this session for the next lecture, I would like to invite Dr. Ashok Verma sir. Verma sir is at present the president of Bharatpur Audio Society, a very senior consultant of the Bharatpur. Thank you so much, sir. Welcome, sir. Next chairperson is Dr. Sunita Agarwal ma'am. Ma'am is at present the president of the Alwar Society. Ma'am is the HOD and senior consultant at Sunita Hospital and has a wonderful work and awards in her name. Thank you so much, ma'am, for coming and for giving us the time. our next chairperson is the Ashok Naniwal sir. Sir is very good senior and very, a good friend of mine. And he is heading and at present the founder president of the Pali Yoga Society, NU Yoga Society from Rajasthan. So thank you so much, Ashok sir, for coming. And I would like to invite Ashok sir is there? No. Sunita ma'am?
Hello, good afternoon.
Yes, ma'am. Yeah, hello, ma'am. Ma'am, I invite you to invite our next speaker and very
Dr.
dear
Monica.
senior of us.
मोनिका
Yeah, Dr.
को
Monica.
तो इंट्रोड्यूस करने की मुझे लगता है कि सभी ही शायद
Absolutely.
पूरा इंडिया जानता है, जैसे होता है ना पूरा इंडिया जानता है, तो फिर भी
Absolutely, ma'am.
she
Absolutely.
is my
Absolutely.
dear friend of mine, Dr. Monica Gupta. She is MBBS MS gynecologist. She is from Rajasthan. She was the past president of AOGS Society, HOD senior consultant at Dux Hospital, Alwar, hysteroscopic laparoscopic surgeon awards. There are so many awards for Monica. Best Zone, Best Zone Public Awareness Committee coordinator, organizing president of Alwar Con, past president of Alwar, I already said. Foxy Achiever Award at West Zone, Yuba Foxy, Dira Trainer, Manita Assessor, Founder Secretary of Alwar Obstetric Gynecologic Society, received Times of India Award, Rajasthan Gaurav Award, prestigious Maharaja Mewar Awareness for Excellence in Working for Public Awareness in Breast Cancer and non-surgical hygiene. NGO, Inner Wheel and Rotary. बस मोनिका you have so many. मेरे को तुम्हारे को bless करती हूँ कि फ्यूचर में भी तुम इतने सारे अवार्ड लेते रहो और अलवर का नाम रोशन करते रहो.
Thank you, Didi. Thank you very much for the kind words. Should I share my slides?
Yes, ma'am. Sure, ma'am.
I want to say one thing about Monica. She is very helpful. Always
Yeah,
there for me.
definitely, ma'am. Definitely. I know. And today this program, if it see the day of a life, it's all due to Monica, ma'am. So thank you so much, ma'am. Yeah.
Can you see my slides?
Yes, ma'am. Yes, ma'am. Yeah.
Could I start? Thank you, chairpersons, all my dear friends, for such a nice introduction. Today, my topic is on vaginismus. Is it really a nightmare for the lady? Yes, because it affects the sexual relationship, couple relationship, and many a times more complication leading to divorce, infertility, and so on. So it is very important for us to know about it.
Sorry to interrupt, ma'am. Can you make it full screen, ma'am?
Is it not full screen?
No, ma'am.
No, ma'am.
Full screen. Now it is full screen. It's okay?
Not yet, ma'am.
Not yet, ma'am.
Ma'am, I request you to reshare it, ma'am.
Okay. Stop sharing.
Yes, ma'am. Stop share and then again reshare it.
Now, is it okay? Is it okay?
No, ma'am.
No, ma'am.
My screen it is there, sir.
Okay, maybe some issue. But you can go ahead, ma'am. Your slides is visible, isn't it?
Yeah.
Sunita, ma'am?
Okay, ma'am.
Yeah.
Well, my screen is visible. Yeah, I can see.
Yeah, me too.
Yeah.
The vaginismus, this term was first described by Dr. J. Madison Sims in 1862 as reflex-like contraction of the circumvaginal musculature resulting in non-consummation of marriage. It was defined as recurrent or persistent involuntary spasm or constriction of the musculature surrounding the vaginal outlet and outer third of the vagina that interferes with the
Ma'am, your
vaginal.
slides are not moving. Sorry to interrupt, ma'am.
Slides are
Your
not
slides are.
But I can move from here. Just a minute. I don't know what happened. Now, is it visible? Is it visible?
No, ma'am. It's no, ma'am. It's actually not shared now.
Not moving. एक बार भेजना उसको अनु को.
Ma'am, just open it in your background and
Okay,
then
I've opened
click
it.
share.
Then I shared. Share screen. This is open. Now sharing. I have asked someone to help me also share screen.
Green button is there. Green light is there, share screen.
This is something else, I think. This is difficult.
Ma'am, click on share screen and then share.
Before that, ma'am, you were sharing the screen, but your slides were not moving.
That's a problem. Arun ko बुलाना एक बार. वो गया कहाँ? इसको भूला. I don't know what happened.
Ma'am, you can do also one thing. Either you give the PPTs to me. आप मेरे WhatsApp में email पे आप send करो, मैं आपके behalf में उसको share करता हूँ.
एक second. I don't have it. मैं उसको एक बार अरुण का क्या बुलाना? मैंने बोल तो दिया उसको. Because I have got in my computer only.
एक बार वापस चला.
मोनिका, उसको तुम पहले ओपन कर लो बिफोर शेयरिंग.
Yes, ma'am, absolutely.
जो तुम्हारा पीपीटी है ना, बिफोर शेयरिंग उसको ओपन कर लो स्क्रीन पर, कंप्यूटर स्क्रीन पर. फिर उसके बाद शेयर करोगी तब हो जाएगा. अगर वो ओपन नहीं है तो शेयर नहीं होगा. अपूर्व, उससे ईमेल करा लो आपको अपने.
हाँ जी मैम, वही कर रहा हूँ मैम, तो बोल रहा हूँ.
What you have sent to me? You have got that slides. It's the same slides.
Yes, ma'am. Yes, ma'am. I got your slides and I am sharing it.
Okay. मैंने समझ नहीं आता क्या होता है अपने में. क्यों नहीं होती?
वो आपने बंद कर दी. खोलो दोबारा.
हाँ, दोबारा कर देखिए.
Is it visible now?
Yes, ma'am.
अब उसने कर दी.
Yes, sir.
Full screen?
Yes, sir. Full screen.
Yeah, ma'am.
Okay, sorry. हाँ. अभी ये चाहिए कैसे?
Yeah.
Yes,
Please
sir.
go ahead.
Okay. The vaginismus, it was a term described by J. Madison Sim in 1862 as a reflex-like contraction of the circumvaginal musculature resulting in non-consummation of marriage. change. Earlier, it was described as a recurrent or persistent involuntary spasm or constriction of the musculature surrounding the vaginal outlet and the outer third of the vagina that interferes with the vaginal penetration. But recently, International Definition Committee in 2005 described it as a persistent or recurrent difficulties of the woman to allow vaginal entry of a penis, finger, or any other object despite the woman express wish to do so. She is willing to do, but she is not able to do. There is a reflex contraction of the muscle. Mainly, female sexual dysfunction are described into three parts: orgasmic disorders, interest or arousal disorder, and genitopelvic pain penetration disorders, which include dyspareunia, vaginismus, and non-coital sexual pain disorder. And today we are going to discuss on vaginismus. Next slide. When we see to the prevalence, exact prevalence is very difficult to know because it needs gynecological examination to find out the incidence, and the patient usually avoids it. Worldwide, it is around 0.6 to 7%, but it can be as high as 17% into our clinical practice. Next slide.
Yeah, already it's there.
It is into the primary and secondary. Primary is lifelong, when she never had an intercourse, and secondary is acquired, where there's previous history of vaginal penetration without any difficulties there, but now she is having problem. Second classification is complete, partial, and situational. Complete is inability to place anything in the vagina, and partial is permission for few occasions, like gynae examination with difficulty can be done, tampon insertion is done, but cannot have a penetration. And situational is when in few situations patient can have intercourse and in few she can't. Next. Etiology include non-organic causes versus organic causes. Next. In non-organic causes, there is a psychosomatic disorder, phobia, conversion disorder, in which body expresses the psychological fear of penetration. As vaginismus, there is an involuntary uncontrolled contraction of the muscles in reflex to avoid injury. It can be secondary to fear, anxiety, and it is a defensive contraction of the perivaginal muscle. Many times, women can have a negative perspective of sexual activity. Next. A variety of psychosocial factors may be responsible for it. When the patient feels sex is wrong, dirty, sinful, shameful, she feels guilty of doing it because of strict religious orthodoxy. She is having disgust regarding genitalia, homosexual orientation, or the penetration will cause pain, injury, or bleeding. There can be a fear of pregnancy, childbirth, or AIDS, so she wanted to avoid intercourse. There can be a history of sexual abuse at the young age, and in these patients, vaginismus is twice as common as the general population. Next. Organic causes include lesion of the external genitalia when the vaginismus result because of the natural protective reflex to pain. There can be hymenal abnormalities, STD, genital herpes, warts, thrush, obstetric trauma, or mechanical injury induced painful scar, endometriosis, or post-radiotherapy. Next. Atrophic vaginitis, what we see in the postmenopausal woman, because of the estrogen deficiency, penetration becomes difficult. Pudendal neuralgia, PID, pelvic organ prolapse, tumor, malignancy, comorbidities like diabetes, multiple sclerosis, spinal cord injury may result in poor lubrication, insufficient vaginal expansion, and there's a pain and reflexly vaginismus occur. Pelvic floor muscles are innervated by limbic systems. So, in cases of emotional stress states, there can be vaginismus, and they are the most common causes for situational vaginismus. Next. Now, Which muscles are mainly involved in vaginismus? They are the outer third of the vagina, pelvic muscle, and perivaginal muscles, including bulbocavernosus is the main one, along with levator ani and pubococcygis muscle. Next. The grading of vaginismus was done by Lamont. By doing a gynecological examination, he graded into 1 to 4, and 5th grade was given by Passig. In grade 1, there is a mildest form of vaginismus, and just we counsel the patient while coaxing she can allow the gynecological examination. In grade 2, there is a spasm of levator ani muscle persist, and patient is unable to relax, but we can do the examination. Grade 3 is a severe form of vaginismus in which patient avoids examination by elevating the buttocks. And in grade 4, she elevates the buttock, retracts and abducts the thigh, and with dorsal arching to avoid vaginal examination. Grade 5 was added by Passig, in which there are visceral symptoms like shaking, shouting, hitting the doctor, jumping from the table. She wants to avoid gynecological examination at any cost. Next. Now, how the patient presents, we all know, mainly as a non-consummated marriage case at sexual dysfunction clinic, even in the infertility center, as many of our seniors has told, they come up and we diagnose them at that time, or while we are doing the gynecological examination, the mild vaginismus can be diagnosed. Next. How it is going to affect the patient life, affect the personal distress, anxiety disorders, leading to dyspareunia. Even the divorce is a common outcome for many of these patients. Male partners even develop sexual dysfunction because of unsatisfaction like erectile dysfunction and premature ejaculation. Next. Now, how we can diagnose. So most important thing is careful history taking and unhurried methodical examination only when patient allows us to do. We have to make patient comfortable, avoid embarrassment, provide privacy, confidentiality. We should be non-judgmental and we should allow sufficient time, sufficient sessions, because it is very difficult for the patient to open up in the first sitting. So she should have confidence in us. Only then she will tell about her problem to us. Next. When we are taking the history, we should acknowledge her, observe her, listen to her. Our body language is like that. We are interested in her talk. She should not feel that we are not interested. We should not see here and there. We should not scratch our head, and we never show. We should always show respect, empathy, and genuineness, and we should have a very good communication skill. Only when patient is comfortable with us, then she is going to tell us about her problem. Next. In history taking, what points are important? First is, what is her concept and belief? What influences vaginismus? Why she is having so much of fear? What is her expectation? What is her phobia? Is she fearful about pain, pregnancy, HIV, or AIDS? What is her family background, religious and cultural background? Is she feel that sex is coming as a punishment because of marriage? Sex is sinful, feel guilty doing the sex? Or what is her sex knowledge? In spite the patient is having a very good educational status, her sex knowledge can be poor. What are her post-traumatic sexual experience? Is there any history of sexual abuse or rape in the earlier life? What is the domestic and social reasons? What is her stress in the work and financial stage? What is her sleep pattern? Whether it is her first marriage or there's a history of previous marriage, and what is the reason of divorce if she is remarried? Is there any history of domestic violence and sexual violence? Because all these things are going to precipitate vaginismus. Next slide, please. Now, the most important thing is what type of bonding she is having with her partner. Is there any fear of rejection, humiliation, or the performance pressure? Is there any lack of affection in the marriage? Is the marriage without her wish or it is forceful? What are her interpersonal relationship? What type of sexual activity she indulge? And in which situations she have vaginismus and how it is modified? Is she taking any medicines that is affecting sex desire? What is her sleep pattern? Many a times musculoorthopedic pain like arthralgia in the spine and back pain can also lead to vaginismus. Next. Now, the sexual history is a key important. What is her sexual orientation? How she feels? Is there consummation of marriage has occurred or still it is non-consummated marriage? What is her frequency, desire, initiation, erotic thoughts, interest during the sex? Is lubrication proper while doing the sex? See, whether she is having the same or different experience with another partner, if any. What type of foreplay or sexual activity she indulges? Is she has having a masturbation practice? We can ask different type of questions to her also. Next. Next. And then we evaluate about the medical disorder, chronic diseases like diabetes, hypertension, COX, kidney, liver disorder, cardiac condition. We should go for the hormonal assay, thyroid, prolactin, LH, FSH, and testosterone. And the gynecological examination should only be done when the patient is comfortable and allows us. First, we should inspect the external genitalia, find out any pain triggering spot at the genitalia or vestibule. We can diagnose vulvodynia or vestibulodynia. Is there any post-surgical or post-infective scar, that is of episiotomy, Bartholin cystectomy, or any other vaginal surgery? See for any infective condition, examine for dryness or atrophy in the vagina because these are also important causes in menopause, like an sclerosis, thrush, wart, allergy, or cancer. Assess for the muscle tone of the pelvic because in the hypertonic cases, vaginismus can result. If allowed, do a speculum or digital examination. We can differentiate secondary vaginismus by the examination. Deep dyspareunia due to endometriosis or interstitial cystitis, PID, pelvic congestion syndrome, adherent and fixed ovary, uterine condition like fibroid, adenomyosis, ventrofixed uterus, hypertonic pelvic floor dysfunction can be there. Next. Next. Psychological and psychiatric conditions are also important. When the patient is depressed, stressful, anxious, having phobia, low self-esteem, feeling lonely, worthy, helpless, they can lead to vaginismus. Personality type like OCD, narcissistic, anger issues, histrionic personality, and psychiatric condition can also lead to this type of problem. Next. Next. DT include vestibulodynia, vulvodynia, and deep dyspareunia. Next. Now, the most important part is the treatment because we can diagnose the thing even the many times the patient itself says, I am having problem, I am not able to allow something to enter into my vagina, and we can diagnose vaginismus. Or whenever we are doing a gynecological examination and patient doesn't allow us, and then we can easily diagnose the thing. History taking is important, but now how to help her? We should assure her that treatment is available. We should always counsel the couple. Last, if not possible, then only the patient. Sex education and counseling is important. We should, if in case the lubrication is less, lubricants and anesthetic cream whenever there is a painful condition can be advised. Pelvic floor exercises for hypertonic pelvic muscles and systemic vaginal desensitization using of dilators, fingers, and special instruments was important in the vaginismus before the Botox therapy. And now the Botox therapy is important for pharmacotherapy. Anxiolytics is there, biofeedback, psychotherapy, hypnotherapy, cognitive behavioral therapy, sex therapy, Sinate focus, and the most important one is the Botox therapy. Next. Now, desensitization using dilators, which we were using for decades, is the important one, in which we allow we do the dilatation of the vagina. It should be done in GA with proper lubrication, and the dilators are from the size of 19 mm to 35 mm of the material plastic, silicone, and glass. And we can ask the patient to purchase her own dilators, and she can do the first. We have done the dilator, and we ask the patient to remove the maximum number of dilator by her own, because she will feel that this much of my vagina can be dilated, and we educate them how they have to dilate the vagina daily, and it should be under proper aseptic condition. We should ask her to clean the things and do into the aseptic condition, and initially the person's own finger can be used for the dilatation, and later the husband finger can be used for the dilatation. That will reduce the sexual distress and coital fear, pain, and increase the bonding of the partner. Next slide, please. Next. So it is important to tell the patient how to use the dilator, overcome her anxiety, and the progression dilatation should be done from smaller to the larger size. And along with that, we allow the relaxation exercises of the pelvic muscle, and it is mainly used for the minor cases of dilatation. If the result is not there in 1 year, then we should switch on to the other methods of treatment. Next slide, please. In pharmacotherapy, anxiolytic and antidepressant can be used. It can be used along with the psychotherapy or any other form of treatment. Next. Sex counseling is very important. It helps the couple to improve their communication skills, dominate compromised libido, could reduce anxiety and depression, useful for less severe cases of vaginismus, and it can use with as a post procedure in the desensitization and Botox therapy. Next. Sinate focus therapy is the therapy of being touched or of touching by herself or being touched by her partner. It will improve their bonding, and she will not fear when something is coming to her genitalia. She will not feel her foreign, and that will help her to regain alleviate her fear, her phobia, and then she can have a proper intercourse. Next slide, please. Psychotherapy and hypnotherapy are aimed to reducing the anxiety and improve the marital life. Cognitive behavior therapy helps patient understand the thought and feeling that impress behavior and helps reclaim the fear of penetration and avoidance therapy. It can be used with other form of treatment also, and it is helpful into the less severe cases only. Next. Hypnotherapy is a verbal interaction is assisted in order to find out whether the positive suggestions could be effective in a woman's sexual life. During hypnosis, what is a problem, what is leading to vaginismus can be discovered, and we can modify those feelings or fears, and then we can treat the vaginismus. Next slide, please. These are all are used in the cases where she has having history of previous trauma, of previous sexual trauma or history of rape. Now the revolution has come with the Botox therapy. Botox is a heat labile neurotoxin derived from Clostridium botulinum. It is the most lethal substance causing flaccid muscle paralysis, available in 8 forms from A to H, and mainly the A type is used into the therapeutic purpose. Next slide, please. In this, effect starts from 7 to 10 days and it lasts for 3 to 9 months. Toxic dose is very high, that is 40 units per kg body weight, whereas the therapeutic range is only 20 to 200 units. It is contraindicated in myasthenia gravis and Lambert-Eaton syndrome patients. the patients who are allergic to albumin and who are pregnant and lactating. Next slide, please. Now, how we have to inject the botulinum. This is available in two forms, Botox or Diprost. Diprost is less potent as compared to Botox, and it should be injected on 3 points on the puborectalis muscles, and we should avoid the sphincter because if flaccid paralysis of the sphincter muscle will occur, it will lead to incontinence and its effects last for 1 year. Many times repeat doses are required to as fear of anxiety triggers abolish. And the simplest way is we just put a Cusco's speculum and it will obstruct both the sphincter and in the lateral wall. With the insulin syringe, we can inject the dose. Next slide, please. What are the side effects? The major side effect is because of the inappropriate site of injection. If we inject near the anal or urinary sphincter, it will lead to incontinence and patient will have problem till the muscle will regain their strength. Few may experience excessive vaginal discharge and in few cases failure occurs requiring the repeat injection. Next slide, please. Next slide. In PESIC, he has used the multimodal program in which for treatment of vaginismus, he used 100 to 150 unit of ontobotulinum toxin A along with the 20 to 30 ml of bupivacaine with epinephrine injection, and then he dilated the vagina under anesthesia. So desensitization along with the botulinum is used and 97% of the person were able to achieve intercourse using a single woman without the partners using a larger dilator. So he used botulinum along with the desensitization, dilatation of the vagina and got a very good result. Next slide, please. We should include the partner in the treatment because many times patient partner can have a sexual dysfunction like erectile dysfunction and premature ejaculation. So the high success rate is depicted in the trial, highlight the importance of cooperative, non-judgmental partner in the process of treating vaginismus. Next. Whenever there is other organic causes like vestibulodynia, vulvodynia, vaginitis, urethritis, cystitis, or endometritis, we have to treat them accordingly. Next. In last, I just want to emphasize vaginismus is a common sexual dysfunction which is noticed by us in gynecology and in sexual medicine clinic, and we many times a mild grade of vaginismus, we avoid it. Actual prevalence is quite a large as compared to the picture what we see, and many patients, they don't come for the help. It significantly affects the woman's emotional health as well as couple relationship. So we have to treat her sincerely. Proper evaluation, diagnosing underlying causes, ruling out differential diagnosis, determining the severity of vaginismus will help in formulating the best possible regime for the patient. We can use 2 therapies or single therapy, what we fish is helpful for the patient. Next slide, please. In addition to conventional therapy, botulinum toxin has called revolution in this treatment, giving a promising treatment option from mild to severe cases of vaginismus. PESIC gave the multimodal approach of combining different therapies, and we can get a better result and early outcome than a single treatment option. Still, we are researching for the more effective treatment of vaginismus and so that we can prevent the recurrence. Next slide, please. When we can treat the patient, if the patient comes to us and we can treat her, we can solve her problem. So why she should suffer in silence when she has got wings and we can let her fly? Thank you very much. Sorry. Sorry for the disturbance or inconvenience what we had because of the problem.
Not at all, ma'am. It's a wonderful, wonderful, wonderful lecture. So I would like to invite Sunita ma'am, our chairperson. Anna, so please get comment on ma'am's. Ma'am? Yeah.
Monica, your talk was so interactive, informative, and I think you cover every point and every. I think in your talk there is a communication. Proper communication is required. Proper counseling is required, and tender and loving care, respectful care of couple is needed. So I think we gynecologist should infront such kind of sexual disorder, and we should set such type of clinic for such type of patient, because in India every patient need a baby after marriage. He doesn't uh, care about such complications, such type of problem. So it is our responsibility to set up of such type of clinic settings where we can give time to such type of couples. So thank you, Monica. Your talk was so nice and informative. God bless you, dear.
Thank you, Monica ma'am, for the enlightening lecture, and thank you, Sunita ma'am, for chairing the session. And now we are moving to our next and the last topic, and that is the panel discussion. Now, when I want to discuss this topic, I know there is always a confusion with the panelists, because we gynecologists are, not very well versed with those type of topics, and it is not covered in our basic medical, syllabus. So, but it is just like a discussion. Me also is like yours. I am a gynecologist, and when I am coming into the sexual medicine before 5 years. So at that time, I started learning the things, and right now I have a separate OPD of the sexual medicines also. So, and it will just like a discussion. We all are new. So nothing to do. Just my purpose is so that we can have the basic knowledge how to identify these type of patients, and to get the basic knowledge of treatment. So my respected seniors and dear friends, thank you so much for giving us the time. We have an expert, Dr. Sudesh Agarwal, ma'am, but unfortunately she is flying at traveling. So probably in between she will join. And we have a very wonderful panelist with us, Dr. Prerna Rathore, ma'am. Rathore, ma'am, is at present the secretary of Hanumangarh OBG Society, and she is a very senior gynecologist at Mahavir Hospital and Maternity Care Center. Thank you so much, ma'am, for coming and joining us. Dr. Prema Kothari, ma'am, is just immediate past secretary of Ajmer OBG Society, a very, senior from the Ajmer, director of the Kothari Fertility Center. Thank you so much, ma'am, for joining. Next is Dr. Bajrang Lal, sir. Sir is the professor and head of the department of the Government Medical College, Sikar, and formerly the principal medical officer and guardian of Arshida Sikar Laparoscopic. He is an laparoscopic surgeon. Thank you so much, sir, for coming. Dr. Savita Lalgaria, ma'am. Ma'am is at present the secretary, just past secretary of the Srinagar OBG Society. She have an experience of 25 years of serving the mankind, and she is the director of the Lalgaria Hospital at Sri Ganganagar. Thank you so much, ma'am. Welcome you, ma'am. Next, we have Dr. Sunita Chaudhary, ma'am. Ma'am, I think ma'am is not joining because, sir, ma'am's husband has undergone some surgery. So she is not well. So, yeah. Monica, ma'am, you are, yeah. Next is Dr. Manju Singh, ma'am. Ma'am is the secretary of the Bharatpur OBG Society. Ma'am is the director and consultant of MG Hospital Private Limited, Bharatpur, Rajasthan. Ma'am is trained in IVF, laparoscopy, cosmetic and aesthetic gynae, and whatnot. Thank you so much, ma'am, for joining us. Next is Dr. Neha Shri, ma'am. Ma'am is at present the secretary of the Kota OBG Society and very senior gynecologist of the of Kota. Next, is Aditi ma'am. Aditi ma'am is associate professor and fetal medicine consultant at Medical College Jaipur, and at present she is the secretary of Jaipur OD Society. She is being a lot of awards in her credit. Thank you so much, ma'am, for coming and giving us the time. Thank you. So we have a wonderful panelist. Few of the panelists are yet to join, and we will start with whatever panelist we have. So I would like to first start and share my screen. Is it visible?
Yes, sir.
Yeah. So we are celebrating 75 years of independence, Azadi Ka Amrit Mahotsav. We as a gynecologist, let's take a pledge so that we can free our women the suffering they are from the sexual dysfunction. So this is my bottom line message for today. And we have an expert, Dr. Sudesh Agarwal, ma'am, and we have a wonderful panelist. So before we going into the sexual medicine, when I am giving lecture or whenever I have approached a lot of, societies, obvious society, they always, pondering me why it is you are talking about the sexual health. Is it is really important? So important. Now, when we are talking about the sexual health, it is a state of physical, emotional, mental, and social well-being in relation to the sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health required a positive and respectful approach to the sexuality and sexual relationship, as well as possibility of having pleasurable and the safe sexual experience and free of any discrimination and violence. For sexual health to be attained and maintained, the sexual rights of a person must be respected, protected, and fulfilled. That is what WHO told. Now, this itself revealed that what is the importance of the sexual health. Now, coming to what is female sexual dysfunction. Now, when we talking about the female sexual dysfunction, it is the persistent or recurrent problems encountering one or more of the stage of the sexual response. It is not dysfunction unless the woman is distressed about it or is negatively affect the relationship. Now, what does this mean? This means when there is a problem in the sexual response and it actually affects the relationship of a woman to her partner, and it's really caused distress in her life, then we call it a sexual dysfunction. Now, before we consider and know what is this all talking about the different type of sexual dysfunction, we should learn and know about what is the sexual response cycle. So, what is sexual? I think Preetam ma'am is there.
Yeah, ma'am. Yes, sir. Sexual response.
Yeah. Ma'am, can you take this question? What is the sexual response cycle?
Yes, sir.
Yeah, please, ma'am.
Yeah, there are 4 phases of sexual response cycle. First one is desire and arousal. Second one is the like saying. And after that, intromission, that is penetration. And fourth is the orgasm or resolution. And these female sexual disorders correspondingly divided into 4 phases. According to 4 phases, like disorders are the same: desire phase disorders, arousal disorders, orgasmic dysfunction, and sex pain disorders.
Yes. So this is very clear. When we are talking about the sexual dysfunction, this whole sexual actually things has a cycle and it's divided into actually the 3 phases. And when there is a problem of any phase, it's called the sexual dysfunction. So that means when there is a problem in the desire, we call it as a desire disorder. When there is a problem in the arousal disorder, we call it a arousal disorder. Or when there is a problem with the intromission or orgasm, it is the orgasm disorder. That is what it is, so simple. So now coming to next. Just 1 minute. Now, we know the master on Johnson, this actually the sexual response cycle. There is a more sexual response cycle. It contains the excitement, Plato, orgasm, resolution. I'm not going to detail. We just want to know there is a 4 cycle, and the problem in any of the cycle cause the problem in the sexual response. That is what is the sexual disorders. Now coming to classification, Preeta ma'am is there. I think Preeta ma'am is not yet joined. So can anybody take this question? What is the different classification? Manju ma'am, can you take this? Ma'am, you have to unmute yourself. Yeah, ma'am, you have to unmute yourself.
Hello, yeah. First
Yeah,
of all,
ma'am.
good evening to everyone. Now, according to the latest classification, the first it was the DSM 4th criteria for classifying the female sexual dysfunctions. It is the old classification in which, according to the stages of the sexual cycle, there was 4 types of dysfunctions: the sexual desire dysfunctions, the arousal dysfunctions, orgasm disorders, or the sensual pain disorders. But according to the latest DSM-5 criteria, they have categorized and reduced the classification just into 3 types. The arousal and the desire dysfunctions have been classified as single. Second is the orgasm dysfunction, and third is the genitopelvic pain or the penetration disorders. So this is the latest classification according to the Data Statistical Manual of the Mental Disorder DSM-5 criteria.
Thank you. Wonderful, ma'am. Thank you so much. Yes, absolutely correct. That previously the desire and arousal, they clubbed it. The orgasm disorder is another, and genitopelvic pain disorder, which Monica ma'am has beautifully told that it's contained the vaginismus, it's contained dyspareunia, or it's also contains the vulvodynia. So these are the classification, and it is. Now, what is the cause of the different type of female sexual disorder? Actually, I have I am unable to see the names actually. So
Brar sir.
Dr. B.L. Raj.
Anybody can please take it. Yeah. Bajrang sir,
Okay.
please.
I am Dr. B.L. Raj.
Anybody.
I am unmuted. Good evening to all.
Good evening.
Yes.
This is really a very much needed topic, because in the state of Rajasthan, or even can say India, we are not much bothered about these sexual disorders, and even we are not giving our child the sex education, even in school, even in colleges, even in medical science. We graduate and postgraduate students, they also not want to talk on these things. So what are the causes? They are number one, the non-organic causes, say social, cultural, and psychological. And I should say, sex is a neuropsycho and neuropsychoendocrinal and this I should say these like neuro, it is related to endocrines, nerves, and this physical and mental status. So these are the now the organic causes, just the development of the medical and surgical drugs, ignorance, inadequate knowledge, myths and misconception. As you have already discussed, these are some taboos about the sexual sex education. Unreasonable and unrealistic expectation, day-to-day stress, lack of time, exhaustion, etc. Lack of communication, performance anxiety, negative attitude, body image problems, disturbed interpersonal relationship, and male sexual dysfunctions. Next slide, please.
Absolutely. Yeah. Absolutely, sir. Yeah. These
I
are
want
the.
to comment, I want to comment something, because
yes, sir.
Because most of our doctors, they are not knowing what we have to do before the sexual arousal. We should teach all the students about the foreplay, about sexual arousal. We should clearly know the anatomy and what are the sexual points on a female. So we should love, we should care. not directly do this. है ना? So we should have a good foreplay before the sex. And sex education must be compulsory. Even my time, there was a topic of sexual health, female sexual health in gynae book that was not taught to us. So now it should made compulsory even in school education to prevent the teen pregnancies. Thank you very much for calling me. Thank you very much, Dr. Datta. I wish you all the best. You are a young and dynamic gynecologist.
Absolutely correct, sir. You have very rightly point out. It is the time, everybody is looking like, the maternal mortality because it's a pandemic. I am telling you, the sexual dysfunction is also a pandemic. I have seen a lot of divorce. I have seen the suicide due to this pandemic, due to this sexual dysfunction. And as a sexual medicine expert, as I am also practicing sexual medicine, I have saved a n number of couples to be divorced. So it's a high time. And, we OB-GYNs are the first, point meeting whom the patients are coming and they are talking about their sexual dysfunction. So we gynecologists should have a basic knowledge, or else they will go to quacks and their life will be hell. So it is a very right time to have to, and rightly point out by Bajrang sir. Now, what is the effect of the sexual dysfunction? Savita ma'am, over to you.
Yes, sir. Yes, of course. Sexual function is must for day-to-day life and for harmony between couple. If there will be proper sex between couple, they have proper sex life, they will be better and healthy. They don't have any chronic disease. They will don't lose their self-esteem, sense of utility. So sex should be there. There would be no any type of frustration among them and psychological problems. There will be no anxiety, depression, or worry, or unhappiness and irritability. They would be more confident. They will present themselves better in every way if their sexual function is proper. If not proper, there would be marital disharmony. There would be disturbed relationship among the couple and quarreling, fighting, arguments, infertility, of course. A divorce may be there, and it can happen if one couple is effective, means if one is potent but other is not cooperating, there would be some dysfunctioning, or other partner would be affected. And effect on the male would be there if male is not competent, like there is some erectile dysfunction or premature ejaculation, then female will also cooperate. She will be also suffer with these problems. Though both should be proper counseled, both should be proper treated for sexual dysfunction. And sexual life is the must to be healthy and to long live. Yes, sir. Yeah. And in our OPD, sir, we are getting sexual dysfunction problem mainly in newly married couples. They are coming with vaginismus, as regions have been told. Many of the regions are there for vaginismus, and we can counsel them properly. We should be friendly for them. We should proper counsel them and proper cooperate them and to tell them. Or either patients are also coming in OPD with some leukorrhea or some postcoital bleeding. Then we have to deal with them. Like organic if cause is there, we should treat properly. Or patient are fear of to get pregnant. In that cases, we should counsel them for proper use of contraceptive methods.
Absolutely.
Yes.
And ma'am, just I want to tell, many times it is, the improper information. For example, I am telling you, you are talking about the premature ejaculation. The intravaginal latency time in India, the average time is 1 to 3 minutes. Many times the newly married couple is coming to me and the wife is told ki my husband is last for only 10 minutes. So, or 5 minutes. So I told, then it's absolutely okay. Why are you? So actually what they have those figure of, the blue films or the pornography, and they have that mind, that thing in your mind and in their mind. So actually, these are not the patient of premature ejaculation, but due to the lack of the sexual education, and they are very much shy. They are asking about their queries with their friends who are equally, good in sexual medicine, or they are getting information from unfiltered information from the Google or this, and these all things are actually make their life more worse. So giving a good education, and what Bajrang sir has told absolutely is the high time that we should have the sexuality education in schools and college, so that they have the basic information about that. Yeah. So coming to the first topic, that female sexual interest and arousal disorder. Now, what is the criteria for that? And I think Sunita ma'am is not there. Neha ma'am, can you just take up this question? Neha ma'am. Yeah. The criteria, these are the
Hello.
criteria. You just, yeah, speak. Yeah, ma'am.
First of all, good
Please
evening
take
to all of you. Yes. Basically, when we talk about the criteria for the female disorder, interest, arousal disorders, 3 out of 6, there are the 6 criteria, in which the first one is like absent or the decreased sexual interest or the erotic thoughts or the fantasies in the patient. And as per the new criteria, based on the 4 additional aspects on the sexual life, such as the absent or decreased of the initiation of the sexual activity or responsiveness to a partner's attempt to initiate it, or the excitement and the pleasure during sexual activity that is a situational or generalized, arousal in response to sexual cues, such as a written, verbal, and the visual. And the 4th one is the sensations during sexual activity, whether genital or non-genital. So basically, based on these, either 3 out of these are present, then we just label the patient that she's having this a female disorder, sexual interest arousal disorder.
Yeah, absolutely correct, ma'am. When absence or decrease the sexual interest, arousal, thoughts, these are the 6 points, and 3 out of 6 if it is present, and at least these are present for the 75 to 100% of time, and a minimum duration of the 6 months. This is the criteria. Suppose that a female is newly married, and on the second day of their marriage, they come with us with this type of, he doesn't interest and she doesn't interest on. We should not grade is that a case of the female arousal or interest disorder. We at least there should be the 6-month duration, and most of the time, if she is experienced this, then we call it as a female sexual interest arousal disorder. Now, what is the screening? How now, ma'am, this is what we all, even when I am doing OPD practice of this, we have certain questionnaire is available with that. And when the patient are in the waiting area, we are actually give this questionnaire to them. So they have to answer it for yes, no, yes, no, yes, no. So before they enter into our chamber or cabin, so we have a bit of knowledge with us ki yes, this patient might be a case of this. So this is actually a very good screening test, so that we can detect whether she is a case of sexual arousal interest disorder. Now, how to evaluate this type of patient? Manju ma'am, can you please take up this question?
So now to evaluate a hypoactive sexual desire dysfunction case, we have to go for a detailed history and examination. We have to recognize the underlying conditions which are contributing to this reduced desire. Is there any major relationship issue or a physical issue, mental issue? Then we have to solicit more detailed information from the patient about the experience of this low desire. What is the onset of this low desire? Had it been from a long time? What is the duration of it? What are the behavioral adaptation and avoidance? And what is the level of distress between the couple? And close evaluation of the patient will include to take a detailed medical history, which is including the reproductive history too. Any comorbid conditions, endocrine, neurological, cardiovascular, and psychiatric disorders, especially thyroid one. Then use of some prescription or over-the-counter medications which the patient may hide, or we may not elicit that history. We have to take the detailed history. Then we have to further investigate and go for the management.
Absolutely, absolutely correct, ma'am. As we know, in any of the disease, we have to take the history, the examination, and everything. So same like here, we have to get a detailed history. Now, this is the main problematic. Why this is main problematic? Because in other things, when in other conditions you are asking the history, they are freely yes, रात में ये होता है, दिन में ये होता है, evening ये होता है. But this history is very personal of them. So probably if you are in a hurry and you are not giving them the proper time, they definitely not open up with you. Because so many times even at least one patient take 30, maximum it can take 30 minutes to open up the things, and we gynecologists are so busy. We have to do cesarean, we have to do hysterectomy, we have to do this that laparoscopy, we have to OPDs, we have to attend the webinars and all the things. So we are actually in a hurry. So this is really very difficult. So that's why those the format, the history taking format is really very helpful. And you just have to tell the patient now, whatever we written in that format, it is absolutely between us only. Even I will not tell the things with your partner. When they build a rapport with the doctors, then only they will open up with you and they will share their very intimate things. So this is again very tricky, and really I am telling you, in a 90% of cases, only taking the history and giving the counseling, you will go through and the patient is cured, and literally you will fill the diagnosis. So after evaluation, now the management, and for the management part, Neha ma'am, yeah, over to you.
Definitely the management counts, and the counseling plays a very important role, because these kind of couples are very distressing, especially the newer ones. The male, as well as the female, as well as the male, both are very upset. So definitely we need to counsel them, and brief office-based counseling is really very helpful. We do have the many models like the preset model, allow, and the me-based. In this, first of all, in the preset model, we can have some permissions and a very limited information to them, including specific suggestions with the intensive therapy. It's kind of a stepped-up approach, which any general healthcare provider can have with these females or the women with the sexual concerns. Another model is the allow model, in which we just allow them, like the ask and the legitimate limitations are there, and then we open up and then work together to seek the solution of the problem. And another model is the Libby's model, in which we have the mind, emotions, body, energy, and the spirit. We just eventually involve all those things, just include the patient, and we have to be along with the patient. Definitely, we have to be very patientfully. We need to give the time to the patient, as you said, in our busy schedule, to counsel the patients. Definitely counseling is must. And apart from the counseling, we can have the psychotherapy for these patients also. In the form of the psychotherapy, we may have the Sensate Focus, as a Monica ma'am well said regarding the Sensate Focus. It's definitely a graded series in which we just need to reduce and the calm, basically to calm the anxious couple. And we just need to improve their sexual communications between both of them, their intimacy, and definitely the final outcome. Apart from the Sensate Focus, we can have the cognitive behavior therapy, in which we just give more focus on those factors, on those thoughts which inhibits or distracts the sexual situation with a specific focus. And in the part of the therapy, we just have to change the behavior, focusing on the pleasure, not on the sexual form. So basically, it's all plan-based, and we definitely need the involvement of both the couples, basically both the husband and wife. And the third resort is a pharmacotherapy, in which we have the vasoactive drugs like sildenafils, or the hormonal preparations like the testosterone, which is well said as a hormone of the sexual drive, and the DHEAs. Apart from this, we have the buspirone and the flibanserin. Definitely, I personally never use them apart from the counseling part. But as per the literature, these are the available therapies.
Wonderfully explained, ma'am. Now, this is again very, very important. And, we are always, even when we are studying psychiatric in our medicine, they are always talking about the cognitive behavioral therapy. And we've always confused what is all these things. Now, I'm taking a very simple example to take this, what is these all therapies? For example, cognitive behavioral therapy. Now, I have one couple, okay, just newly married couple, and the wife is saying he doesn't have the interest. What happened during their marriage? There is some quarrel between those in-laws. ठीक है ना? So जो लड़की के जो मामा जी थे, वो लड़के के मदर को कुछ उन्होंने बोल दिया था. So that there is some problem in that mind, वो उस चीज को भूल नहीं पा रहा था. So she doesn't have that interest with the wife because she has that point in there कि भैया उसने शादी में मेरे मदर को insult किया था. So these are literally, I'm telling you, these are and after taking all the history, all the detail, the sexual orientation, everything, I find nothing. But मैंने पूछा कि ऐसा कुछ हुआ था कि family, and they are saying yes, this happened. So these are when they have something उनके मन में घर कर जाता है, we take the cognition of the patient, like what they have in their mind. First take that and we have to correct that. कि वो जो believe कर रहे हैं, if they are believing कि having I have to last for 30 minutes. So first we have to take that belief, what's their belief, change their belief, and then do the therapy. That is the cognitive behavioral therapy. Means we have to talk the patient, take the permission what they are in mind, and we have to correct that thing. Then it is up. Now what Monica ma'am has and Neha ma'am has told about the sunset focus. It's really very wonderful. What is sunset focus? I just take 30 seconds to explain it. First, there is we just ask the patient, okay, go to your bed and just talk, how are your day, office mein kya raha, kaisa raha, and just talk 2 weeks like that. On the very after 3rd weeks, when they have a very good relationship, friendship, do hafta karne ke baad, on the 3rd week, they, wow, today when you wear that sari, you are looking so wonderful. Wow, your hairs are so good. Now come to the non-sexual verbal talk. That is the second stage. Now, third is the sexual verbal talks. Okay, your breast is so good, your skin is so good, and that is the third. The fourth step is having the non-penetrative sexual intercourse, like kissing, hugging, cuddling, and all. And finally, it is the penetrative intercourse. So these are the 5 steps of this model, that is the sunset focus. And believe me, these all are might be hearing and looking ki bhai ye kya hai, but it does work, it does wonderfully in the patient. You just have to explain, take your extra 1 minute, explain this, and this do happen. Now coming to that pharmacotherapy, these 4 drugs which I am using, and it is freely available in market, and you all can use. One is the sildenafil citrate, 25 milligram OD every day for 3 months. Really, it's do wonder. It's do wonder. One major problem with this drug, actually, it caused what happened? It caused the blue vision and headache for the some patient, but it does has a wonderful. Second, our old friend DHEA. We are all using this in low AMH, in secondary infertility and everything. Now, this is again very, very important, especially in perimenopausal lady, where the hormones level are, reducing. The ideal dose is 70, it is 100 milligram per day, but in Indian market, we have a DHEA 75 milligram per day. So give the 75 milligram per day orally for 3 months, and you will see the results. The third, which is available in our market and it is available everywhere, is the testosterone. Again, the injection is available, the gel is available. Where there is an IVF center or say everybody, because IVF people are using this. So gel is again very important, and just has a pinch of it and just apply over the skin. It does happen, and you have to maximum we can use it for 6 months. So these three you can easily available everywhere in India. You can use it and it has a wonderful results. Now coming to
Just to
female
interrupt.
orgasm disorder. Yeah, yeah,
Hello?
ma'am.
If we are using injectable testosterone, what are the dosage?
Ma'am, it is available like in Dhanbad. In our city is available 250 international unit. Yeah. So it is like initially we have stat OD. Then after every 3 weeks we are using up to 6 months. That is the dose. So it is using and it has a wonderful result. What I see. Now the second is the female orgasm disorder. Aditi ma'am is there. Aditi Bansal ma'am. I think Aditi ma'am is there.
She's
Aditi
not there.
ma'am. Okay, she's not there.
The pardon, sir, testosterone injections per day for how many days, sir?
No, it's a weekly, ma'am. First you have to do a start. Then it's a female, and in male we are using can be using, but in female every 3 weekly for 6 months.
Okay, thanks.
Okay, and it is just a wonderful results. Yeah. Now the next is the female orgasm disorder, and I think Pritam Rathore ma'am is there. Is she joined? Yeah, ma'am. Can you take up this question, ma'am? Or anybody can this question? What is the female orgasm disorder?
Yes, sir.
Yeah, ma'am. Savita ma'am, can you take up
Yeah.
this, or Neha ma'am or Manju ma'am? Yeah.
Okay, sir.
Anybody? Yeah, Savita ma'am, please.
Yes, sir.
Now, what is the definition actually of female orgasm disorder? Yeah.
Yeah, it's again delayed, infrequent, or absent orgasm, or markedly decreased intensity orgasm after a normal sexual arousal phase on all or almost all occasions of sexual activity. It may be distress or interpersonal problems due to orgasmic dysfunction, or no other disorder or substance that exclusively accounts for the orgasm dysfunction, or symptoms may have been present for more than 6 months. In that case, we will call it as
It's an absolutely
orgasmic disorder.
Orgasm disorder.
Yeah.
In any
There are-
female sexual disorder or any disorder, these are two things is common. It should be minimum for 6 months, first thing. And secondly, it should be 75 to 100% of the times he is experienced with that. So next, what is the type? Prima ma'am, are you there? Prima Rathore ma'am, I have seen her. No? Bajrang sir, can you take up this question? Bajrang sir?
Okay, I'll take it.
Yeah.
Now
yeah.
the types, share the slide. Types. It may be primary or secondary. In primary, the women have never been able to have an orgasm. And in secondary, women were previously able to have an orgasm, but are now no longer able to do so. And third one is situational. The most common type of orgasm dysfunctions occur when you can only orgasm during specific situation, such as during oral sex or masturbation. And fourth one is the general. An inability to achieve orgasm under any circumstances, even when you are highly aroused and sexual stimulation is sufficient. So these are the 4 types of the
Absolutely.
orgasm
Now, this
defect.
is again very important, because if it is a secondary, it's a very easy to treat, because there may be some factor, the organic factor or something or some psychological, you remove that factor and they're absolutely okay. If it is primary, then definitely we have to look after the things, and it is really a difficult one. So management part, Bajrang sir, can you take up the management, the behavioral therapy?
Yes, behavioral therapy. We should there is direct masturbation, sensate focus therapy, sex enhancement technique or sex therapy, relaxation techniques, mindfulness, hypnosis, or systemic desensitization. I have already discussed on this, because before it is sex is a psychosomatic disease. It is psychosomatic. It is not because neither is psycho nor is psychosomatic, endocrinal and neural. All the four organs should be better. And we have improved as you have said, sense and focus therapy, as you have already discussed in detail, and the sex enhancement techniques, because some persons say I have no orgasm in the same position. So sometimes they were asked to change the positions, just like in Ajanta and Aurora, they are having such types of techniques for sexual intercourse. So we can teach them and we can advise them to do like this. And also the relaxation techniques as with yoga and all these, and hypnosis and systemic decisions as you have already told in detail.
Yeah. Just I want to emphasize one thing. What is mindfulness? Now, many a time I have asked the patient, what happened when they are going to the bed? They have many things in mind. आज बॉस ने डांट दिया, आज घर में ये झगड़ा हुआ, कल को वो टेंशन है, बच्चे का रिजल्ट नहीं हुआ. So when they have come, and that the bedroom, they have everything in their mind. And that is one of the problem. They doesn't grew that interest. If able to grew that interest, they are unable to perform. So, भाई जब आप कमरे के अंदर जा रहे हो, remove everything outside your bed. That is mindfulness. Means when you are in the bed, just think about yourself, your wife, and in the bed, nothing else. That is what is the mindfulness. Don't many time I have seen the people, भाई भगवान के फोटोग्राफ्स है, हनुमान जी के फोटोग्राफ्स है, और उसको हटा नहीं सकते भाई, वो बुरा मानेंगे. भाई भगवान जहां होना चाहिए वहां पर है, पूजा घर में है. Make it, you can have Sunny Leone photo at your bedroom, but please don't put any Bhagwan's photo.
Even the Vastu says no photo of God should be there in bedroom.
In the bedroom, yes. Yeah. Even our culture, हमारा जो सनातन धर्म है, our culture is, they are saying that bedroom
Only
में no such photographs should be there.
Love photo we can have in our
we
bedroom.
Can have.
Otherwise, no God photo should be there.
No God photos. That is what mindfulness. Whenever you are in a bed, leave everything outside you in your bedroom, and it should be you, your partner, and the intimate movement. That is what is mindfulness. This is again very important. And when you many a time, because the husband wife both are working, and they are so much distressed. So I always advise them to have a sexual intercourse in the early morning, because many a time when they came, yeah, तो वो दोनों थके हुए हैं, कुछ नहीं, आते हैं सो जाते हैं. So in the morning time they can have if they want, they have this sexual intercourse.
Dr. Apurva, basically mindfulness आजकल वैसे भी बहुत ज्यादा और therapies में भी use होता है. Simple, yes, being present at that moment in any
at the moment. Absolutely.
You have to be present at that moment.
I just want to add one point also. You should leave your mobile aside, because all the time what happens, the husband is on one mobile and wife is on another mobile, and that is also a problematic thing.
Yes,
absolutely.
Mother-in-law.
As Madam Monica said, this is really a problem.
Yeah.
As soon as you think about it, there is a call from labor room.
That is a different thing. That is a different thing. वो तो obstetricians के लिए वो तो obstetricians का हो गया, वो तो झेलना ही है ना, वो तो कुछ नहीं है.
Absolutely, ma'am. So after this, the medicine therapy, and Pritam ma'am is not there. So I just read out this. Yeah. Pritam ma'am is there. Yeah, ma'am. Ji ma'am. Thank you so much, ma'am, for joining. Pritam ma'am. Pritam ma'am, you have to unmute yourself.
I saw her joining.
Okay. Yeah, actually, ma'am, Pritam ma'am told ki in Ajmer there is thunder and all. So probably in between, yeah. That is
it's raining in Rajasthan. All over the Rajasthan, it's raining.
Yeah, it's raining here also.
You are blessed, ma'am. We are blessed. We have a 45-46 degree temperature in our place, Dhanbad. So about the medicines, I already discussed about the Sildenafil. Now, what Sildenafil do? It's actually it increases the blood flow in the vagina. it's just so that it's actually increase the desire as well as it's cause the orgasm if it is not there. The hormonal therapy is again very important in case of perimenopausal and menopausal therapy. Many times the surgical removal of the ovaries at a younger age, less than 40, cause this orgasm disorder. And the estrogen therapy and Tibolone and HRT is actually doing wonderful. And in cases of perimenopausal, DHEA, testosterone are actually doing that. Many times, I just wanted to say one thing, many times OCPs, even very long-term OCPs, though data is insufficient, is still, but few data is actually saying, and what I have seen in my practice, OCP is taking more than 10 years. There is some problem, probably the dry vagina or there is suppression of the hormones. I don't know what's the reason, but many times and I have a few patients where I just stop the OCPs and ask them to have some alternative contraceptive, and this problem is solved. So we have a very nutraceuticals nowadays, over-the-counter medicines. I must sure that the MRs are coming with you also, like L-arginine or something like that. But these may have effect, probably psychological, but FDA doesn't approve that. So this is the over-the-counter medicine and antioxidants. Now I am not going to tell vaginismus. So actually Monica ma'am has so much detail into that, and so it's just a revision definition. Ma'am can be Savita ma'am, you are also doing the cosmetic
Yes, sir.
gynae. You can just quickly take up the same thing. Savita
Yeah,
ma'am,
we can
what is
treat this vaginismus, sir, by sex education after counseling and lubricants, anesthetic creams, and pelvic floor exercises. Definition we have discussed, I think already discussed, no? Its earlier definition of recurrent or persistent involuntary spasm or constriction of the musculature surrounding the vaginal outlet and the outer third of the vagina that interferes with vaginal penetration. And recent definition, that is, it indicates the persistent or recurrent. Should I share? Difficulties of the woman to allow vaginal entry of a penis or finger or any object despite the woman's expressed wish to do so. So we should go for treatment. Grading we have discussed already.
Yeah, ma'am. So treatment, I am just want to Manju ma'am. You are also doing the cosmetic gynae. So just what's your ma'am? Just your practical points. What you want to do in these cases? How you will treat, Manju ma'am?
First of all, I have to assure that patient that treatment options are available. It's not that the disease or the ailment is not curative. So we have to confide in the patient that yes, treatment options are there and you have to go for it. And it would be a gradual result. You won't get the result very abruptly. Then we have to address the medical condition to the patient, give the proper sex education and counsel. Then the use of various lubricants, anesthetic creams, it's very gradually. First of all, we'll ask the patient to mindfulness, like you should be present in that moment, then use some lubricants, some anesthetic creams. If doesn't work, start with pelvic floor exercises. Then the systemic vaginal desensitization, which Dr. Monica has so well explained, the use of dilators, the fingers, special instruments, then use of anxiolytics in cases of mental anxiety disorders. Physical therapies have to be given with or without biofeedback. Psychotherapy has to be given, hypnotherapy, various therapies which have been discussed in such a detailed manner by Dr. Monica, and the recent use of Botox. These are the management protocols which we will follow, and definitely we'll have results. And if there is any surgical problem, like if there is a septum in the vagina, we have to go for radiolysis after examination under GA.
Absolutely, ma'am. Very correctly told. Neha, ma'am, yours input, please.
So it's about the systemic vaginal desensitization. The Monica ma'am has already elaborated very well that how to basically we can do it in the OT or in the examination room. First, we with the available dilators. They are available from 19 to 35 mm, the variable sizes. First, we insert the small size dilator and then the gradually increases the size and show it to the patient that how it inserts easily. And that is the thing, he first be inserted and then allow the patient to insert it so that it just reduces the anxiety to half. And it's better to have her partner also. We can have also the patient, even the partner's finger can also be done. And it is causing, basically at the time of the insertion of the dilators, we can be assured that up to what size it can be inserted without any pain. And when the husband is also there, the patient by herself dilates gradually to just allay the anxiety, especially when it is a non-pathological. And definitely it is the most common modality of the treatment which we can offer to the patients.
Absolutely, absolutely. Very, very truly. Yeah. Anybody of you are using actually Botox, ma'am? Any okay. I have using only once. That too, I'm taking it. It's a by a pharma company, and they give me that use it. Now, what I feel that only a small amount of patient actually need the Botox, and what I feel it's only the height. What I think the pharma people are actually made, because majority can have, I think by systemic desensitization and all. So this is the thing, I think so. This is the thing. And secondly, only Botox can do the things, because it's not only the anatomical problem, it's also the psychological problem. So, Aditi ma'am, it is very key. You have to give the psychotherapy, the counseling and all part are needed along with this, then only it is successful. Yeah, that is the thing. So dyspareunia, I think we all gynecologists are very well versed. Many times we are coming with the patient having the complaint of the dyspareunia. Now we will take up this question in very shortly, because we are running short in time, and after that Prema ma'am is not there. Anybody can.
Yeah.
Aditi ma'am or Savita ma'am. Yeah, please take it.
Dyspareunia, that is a sexual pain disorder, a subcategory of sexual dysfunction. And the pain must be persistent or recurrent and causes marked distress or interpersonal difficulty. That is difficulty in penetration. And the integrated pain model emphasizes that physical and psychological factors may be instigating causes and regions for perpetuation. So treatment is the same: psychosocial therapy and medication. Medications are moisturizers, lubricants, estrogen, androgens, tibolone, and selective estrogen receptive medications, and neurogens. This is just like vaginismus, and we have to treat organic causes also. Moisturizers have the ability to retain and accumulate water, which is then released locally, resulting in increased hydration, thus mimicking physiological vaginal secretions. And this provides a quick relief for local symptoms, especially dryness. And it can last for days or longer than lubricants. So moisturizers are better than lubricants. While moisturizers are intended for chronic maintenance to replace vaginal secretions, lubricants are specifically designed to reduce friction during coitus and reducing dyspareunia before the act. Lubricants are based on oils, glycerin, or silicone, and usually prescribed as an adjuvant to other local or systemic treatments. And again, we can give local estrogen therapy in postmenopausal cases, sir, like vaginal tablets, vaginal cream, estriol and promistrine is available, and vaginal ring in the form of natural estrogen is available. A typical administration schedule consists of an initiation dose to be taken daily for approximately 2 weeks, followed by transition to maintenance therapy, that is twice a week for as long as needed to manage symptoms. Again, testosterone, as you have prescribed, the hormone of sex drive and libido, but is also considered important for women's physical and mental well-being. However, long-term safety on cognition and cardiovascular health have to be confirmed. And again, there is synthetic steroids, there's tibolone. It is with estrogenic, androgenic, and progesterogenic properties. It is indicated for the relief of climacteric symptoms in postmenopausal women yielding significant improvement in sexual function, and doses is 1.25 or 2.5 milligram per day. Again, there are drugs, selective estrogen receptive modulators that are synthetic non-steroidal agents that exerts a variable organic or antagonistic or neutral effect on the estrogen receptors of the target tissue. Drug is osmifene 60 milligram daily orally. Is proposed to those women who are not eligible for vaginal estrogen therapy. Orally, it can be taken and it exerts a positive effect on the vaginal epithelium and a minimum effect on the endometrial tissue so that it will not harm and endometrial cancers will not be there.
Absolutely, absolutely. So the basic baseline is if there is an organic causes like maybe that there is a PID, maybe there is a deep endometriosis. We have to rule out that. If it is ruled out, then we have to, many times it is the psychological, and these type of moisturizer, it's a freely available, and even just leave about these moisturizer, simply aloe vera gel, which is actually available. These actually do wonder, and many times these gel actually have a psychological effect. कि भाई कुछ है तो maybe I am getting less pain, so they are able to perform. So actually we have to rule out the cause. If there is no organic cause, then we have to go for the psychotherapy along with these lubricants, gels, and which is available over the counters. And not going to detail, we have now the different type of aesthetic procedures are there, and so improve their look of the vagina, and so improve their sexual dysfunction. So the take home message is before I'm going to take home message, I just want a comment from each of the panelists about your thinking, starting from Manju ma'am. Yeah, please ma'am. You are a senior, and what's your about this, and who we gynecologists, what should we learn about it? Yeah, what's your thoughts?
First of all, I would say this webinar was very important for us because it's a rarely touched topic. We haven't read much about this in our MBBS or PG time.
Absolutely.
So that was really fruitful for us. Confessing, yesterday only I had a case of grade 5 vaginismus. And because I was a panelist in it, so I had gone through a little literature, so I could actually properly counsel the patient. And really I was feeling confident कि हाँ मैं आज क्योंकि webinar में participate कर रही हूँ डॉक्टर मोनिका की वजह से, तो मैंने ये थोड़ा पढ़ा और उसको ढंग से समझाया, उसे counsel किया. So sexual health is really important for a quality of life, and it is a very, very common disorder. It is to be properly addressed. It is to be properly counseled, and we, the gynecologist, as the first line meet of the diseased or the affectee, we should properly guide. And if there is any other surgical correction needed, that is to be also counseled properly. That is really very important.
Absolutely. Thank you so much, ma'am. Aditi ma'am. Yeah. No. Neha ma'am. Your comment, please.
First of all, I would like to say thanks to the Monica ma'am as well as to you. That really it was untouched topic and one of the very hush topic, because definitely in our PG time we have not, actually it was there in the books, but we have not given that much of importance because it was never being asked in the examination. That is why. In our day-to-day clinical practice, even we used to thought that it is a topic of the psychiatrist as well as a psychologist, and their. So basically what we have to do, whenever we combat these kind of patients, we just say, send them to the psychologist for their counseling sessions. But definitely, sir, now onwards, we will first of all handle this kind of patient, and suppose being the gynecologist must be the one stop rather than first stop for this kind of a patient.
Absolutely, ma'am.
Thank you.
Savita ma'am,
Yeah,
your comment, please.
it's a fantastic, sir. And as you know, you are also practicing and counseling. You are feeling the pain of ladies, of women.
Okay. Absolutely.
Yes, sir. And sir, I also want to know, for male also, you just tell the for premature ejaculation, the drug, the most useful or most that is not having any side effect, because they are taking
Duloxetine. Madam Duplexity, first of all, many time the good sexual medicine people,
Anxiety.
what they are saying, it is not the premature ejaculation, it is the
Anxiety.
early orgasm.
Yes.
So the first thing, the counseling part, then stop in and stop out technique. This is again very important. And duloxetine is the drug of choice in that case. But you have to be, counseling is very important. And it is, entirely different station, ma'am. I will just send you the name. And I will also share you where
Name
we
and
have a
trade
webinar
names.
with the premature ejaculation and erectile dysfunction. And really, these all things are curable. And it is nothing like these are not curable.
Because some men are
yeah.
using this sildenafil or Penegra, that's causing headache.
Yeah, that is the side effect of the sildenafil citrate.
Yes.
When you are coming to the label 2, that is tadalafil. When we are using tadalafil is safe. If the patient is hypertensive, diabetes, cardiac disease, or anything, आंख मूंद के आप tadalafil दे दो. Tadalafil is a wonder. You can start from a very low dose like 5 mg once daily. It has, once daily, 6 months, 1 year, and it almost, it's a very side effect free. Okay. So I will definitely share in you and also in
sure,
group, and it's a wonderful drug. So tadalafil is there, but tadalafil is basically for erectile dysfunction, not for the premature ejaculation. For the premature ejaculation, duloxetine is actually the drug of choice now. Okay. So I will share both of this.
Sure, sir. Sure, sir. Because it's also a practical problem. And
yeah,
ladies,
definitely.
don't share, sir. We have to ask.
Definitely.
Dr. Monica, I wanted to know.
Yeah. No,
Hello,
I
Dr.
think,
Monica.
Yes.
Yeah,
I wanted to know about the dilators. How are they commercially available? By what, from where we should get those dilators?
Dilators are available on the Amazon.
Amazon.
You can easily order from the Amazon.
That is the thing.
I think
and the patient should have her own.
Okay.
It's better.
Amazon is the answer for all the questions, I think.
You can
get all the things on Amazon.
That's it.
Amazon is amazing. And
so before that, the take-home message, sexual health is important for quality of the life.
Yes.
Female sexual function is very common. Sexual function can be affected by illness, surgery, medication. Assess medico, psycho, social, and relationship factor. History taking can do wonder, and the counseling cure almost 90% of all the sexual dysfunction. Treat the cause, educate about the anatomy, physiology of genital function, remove the myths and misconception, and treat the couple. That is what the take-home message. And I just, before say goodbye, please support me. For my, at present, I'm the National Coordinator Sexual Medicine Committee. I have been working in this committee, and I just wanted to give this basic knowledge of sexual health, sexual dysfunction to each and every Foxy and each and every society of Foxy across the India. For that, I need your valuable vote, valuable support, valuable blessings.
Yeah, our support.
So thank you so much to everyone.
All the best.
Sure.
Okay, thank you, sir.
Thank you.
Thank you.
Thank you, everyone. Hello, Dr. Sudha.
So before I just want to say goodbye, it's the time to say vote of thanks. And for vote of thanks, I would like to thanks to our chief guest today, Dr. Alka Kirpani ma'am, the guest of honor, Dr. Leela Vyas ma'am, Anju Soni madam, and Neeraj Jadhav sir, to the speakers, the wonderful speakers, the Taru Chhaya ma'am, Dr. Monica Gupta ma'am, the chairperson, Dr. Pushpa Nagar ma'am, Dr. Nikita Thereja madam, Pradeep Bandwal sir, Ashok Verma sir, Ashok Naniwal sir, Sunita Agarwal ma'am, the expert Dr. Sudesh Agarwal madam, the wonderful panelist Dr. Prema Rathore madam, Dr. Preetam madam, Bajrang sir, Dr. Savita madam, Dr. Sunita madam, Manju madam, Neha ma'am, and Aditi Bansal ma'am. And thank you so much, our academic partner or our pharma partner, that is the Shield Healthcare. They are always being there to support us and give us the platform. Thank you so much to all the societies, all the president and secretary Secretary of the Rajasthan, and all the viewers. Thank you. Thank you so much.
Thank you very much.
Thank you. Thank you, Monica ma'am. Without
Thank
your
No,
blessings, it can't be possible. Thank you,
no,
ma'am.
no, it
Thank
was
you. Thank you so
all
much.
your effort. And thank you, Apurva, for organizing such a wonderful webinar for us. And we are looking forward to learn more from you.